The patient, a 35-year-old woman, presents with grade 3 hemorrhoids and a posterior fistula in ano. She is under general anesthesia and has been placed prone in a jackknife position. The site is prepped and draped. A solution of marcaine and epinephrine is injected into the perineum proximal to hemorrhoidal tissue to reduce swelling and aid in hemostasis. Care is taken not to disturb natural anatomic planes. The retractor is prepped with betadine and placed in the anus. The posterior lateral hemorrhoid is grasped with a hemostat and is retracted. Harmonic focus on max is used for dissection, beginning at the apex of the prolapse. The plane of dissection continues, transecting tissue overlaying the internal sphincter. Slight traction, countertraction is maintained throughout tissue transection. The final transection is performed using focus on min. The specimen is removed. The site is inspected for hemostasis and integrity of the internal and external sphincter muscles. The left anterior hemorrhoid is isolated and is grasped with a hemostat. Using a combination of traction, countertraction on tissue, harmonic focus is used to begin transection at the apex. Accessory groups are noted adjacent to the primary hemorrhoid. Tension is released somewhat to ensure enough skin remains intact for skin bridging post-op. A bite is taken under the accessory group with a focus on max, sparing anoderm to prevent future stenosis. Note the field is relatively dry and both external and internal sphincters are intact. Small bites are taken as hemorrhoidal tissue is carefully peeled back, away from muscles during dissection. A suture is placed at the apex to ligate the pedicle prior to amputation. Min is used during final transection. A stitch is placed at the apex to approximate tissue. Another internal hemorrhoid, adjacent to the last, is grasped and retracted slightly. No countertraction is applied. The focus is used to amputate the hemorrhoid on min. The entire internal component is removed without injury to the anoderm. Moving to the anterior area, another large prolapsing internal hemorrhoid is isolated and grasped. Again, beginning at the apex, harmonic focus on min is used to transect the hemorrhoid. Note, no countertraction is placed on tissue during transection. Some oozing is noted. Focus on min is used to control bleeding. The retractor is positioned to reveal a posterior lateral fissure fistula complex. A fistula probe is advanced through the fistula and is used to retract tissue of the fissure. Harmonic focus on max is used to transect tissue. The base of the fissure is observed. Adjacent is another internal hemorrhoid. The internal component is amputated using focus on men. Skin bridges are checked circumferentially. A hemostatic packing is placed in the anus. A small tissue tag is taken with focus on men. Another tag on the fissure complex is taken, and a small bleeder is controlled on men. The specimens are demonstrated.